Hello and welcome to Obcast. This discussion is going to be around primary postpartum hemorrhage, or PPH, which is a really important topic in obstetric emergencies and something that could catch us off guard in the emergency department or pre-hospital setting if attending a childbirth. Now, PPH was briefly discussed in the lecture O Obstetrics, but we're going to spend a little bit more time on it, and some of the aspects of PPH management will be addressed in other videos. So the definition of a PPH is greater than 500 mils of blood loss after a vaginal birth, and greater than a litre defines a severe PPH. Now, it's important to understand that at term, the blood flow to the uterus varies, but can be on average around 3/4 of a litre per minute. So you can see here with a woman's circulating volume at term being around 100 mils per kilo that they can actually rapidly exsanguinate. And postpartum hemorrhage, or obstetric hemorrhage in general, remains a leading cause of mortality in pregnancy worldwide. Now, there's four main causes of postpartum hemorrhage, or primary postpartum hemorrhage, and this is remembered with the memory aid, the 4 T's. So the first T is tone, which refers to an atonic uterus. The importance of an atonic uterus is that at the site of the placental bed, the spiral arteries coming from the maternal circulation penetrate through the muscle fibres. When uterine contraction occurs, these blood vessels are constricted and therefore bleeding is reduced or ceased. If the muscle fibres remain relaxed, well, the calibre of these vessels is larger and therefore bleeding can be profound. The next T is trauma, which stands for genital tract trauma, and that can actually be anywhere from the uterus to the cervix to the vagina all the way to the perineum. And these injuries can be obvious or can be occult, and what I mean by that is you can have vaginal wall hematomas they can hold up to a litre of blood and be, an occult source of hemorrhage secondary to trauma. The third T stands for tissue, and that refers to retained products or placental tissue. And the last T is thrombin, which is a way of remembering primary or secondary coagulopathy. Now, the management principles in the ED or outside of the birthing suite, although they hold true there too, I guess, are to check the T's to try and work out what the cause is, but rub the fundus and call for help early. Obtain IV access and resuscitate. Now, both tranexamic acid is indicated, as well as early blood products and or massive transfusion protocol as necessary. Give some drugs to improve uterine tone, and then do bimanual compression, and do this early. If we think about external hemorrhage of other sources, applying pressure to a bleeding wound is part of the basic first aid. Now, of course, bimanual compression is far more invasive to a woman and can be very uncomfortable, and often requires an indwelling catheter inserted to facilitate bladder drainage. But it is also a very important tool for hemorrhage control, and in the setting of severe PPH, especially outside of a controlled setting, then it should be done early. Now, here's a diagram demonstrating bimanual compression, and the technique is to put your hand into the anterior fornix of the uterus and create a fist, and use your other hand suprapubically to put pressure between the anterior and posterior walls of the uterus. Now, what I'm referring to mainly allows the treatment of uterine atony. Of course, if there's a large genital tract laceration, then in the emergency department, a hemostatic suture can be placed, such as a figure-of-8 style suture with a large 1 or 0 vicryl, and then these things can be addressed later in the operating theatre. I want to summarise briefly the drugs and doses for PPH because they're not medications we use commonly. The first one is ergometrin, and its dose is 250 micrograms IV, which can be repeated 5-minutely up to 4 times. The next medication is oxytocin, and it's given as a 5-unit intravenous bolus which can be repeated, and then an infusion, which have various formulations, but a common one is 40 units in 1 litre given over 4 hours. Now, I make the point here of saying that that infusion provides 1 unit every 6 minutes, and the reason I do that is I've worked with practitioners previously who felt very reassured by commencing an infusion of oxytocin prior to a bolus, and I guess this just needs to remind us of the pharmacokinetics of an infusion, in which case it takes quite a bit of time at this rate to get to an effective dose of oxytocin, hence the initial bolus. The next medication commonly used is misoprostol, which is a prostaglandin, and the dose for this is 1,000 micrograms PR. Can also be given via other routes, including buccally. The last medication used is prostaglandin F2 alpha. Now, originally this was intramyometrial and therefore used mostly in the hands of obstetricians. I've used this before at caesarean section where it's quite easy to direct into the myometrial tissue, but it was described there were techniques to give it transabdominally after a normal vaginal delivery. Fortunately now there's an intramuscular preparation which is just given at a dose of 0.25 milligrams, which can be repeated up to 8 times every 15 minutes to a total of 2 milligrams. So a far easier medication to administer in the setting of a vaginal birth, which is relevant to the pre-hospital and emergency department setting. Now, tranexamic acid is an antifibrinolytic agent, and it's given at a dose of 1 gram intravenously, which can be repeated. Now, this was assessed most recently in the Woman trial, a large international randomized control trial, which found it had a survival benefit, which was increased when given within 3 hours. Now, there, I guess, are some issues with the generalizability of the results and the relevance, to tertiary obstetric practice, given the high amount of patients enrolled from developing countries. My thoughts on this are that especially pre-hospital and emergency department settings are very uncontrolled environments, and therefore the benefit of tranexamic acid is absolutely warranted. I want to touch briefly on some other treatment options, just things that don't occur inside the emergency department or birthing suite. And the purpose for this is just to give some, perspective to the non-obstetrician as to what other things can occur if we can rapidly expedite a patient's transfer to the operating theatre, for example. So in the operating theatre, obviously they can have ongoing resuscitation by a dedicated critical care physician, i.e. an anaesthetist. And then surgical options generally follow the following order. So a woman will have an examination under anaesthetic, where under either a spinal or general anaesthetic, you can have an excellent look at the entire genital tract for any trauma and repair anything that's causing significant hemorrhage at the start. And then a curettage of the uterus with a large uterine curette is often done, followed by the insertion of an intrauterine balloon tamponade. Now, the Bacri device, which is pictured here, is very commonly used now as a tamponade device. Following this, patients can have a laparotomy, at which time uterine compression sutures can be placed to improve uterine contraction, and an example of this is the B. Lynch suture, which is pictured here. Prostaglandin F2 alpha can be injected intramyometrially. Now, I mentioned the newer preparation of carboprost actually recommends against its use, but it can be done and has been done at a dose of 0.5 milligrams intramyometrial at laparotomy. Uterine artery ligation can be done on exposure of the uterus, and although very technically challenging, it's possible to do internal iliac artery ligation. The endpoint of surgical PPH treatment is a peripartum hysterectomy, and it's important to remember that interventional radiology procedures such as uterine artery embolization can be used, but patient selection is important, and understanding what resources are available in the radiology suite in terms of having an unstable patient always need consideration. So Obviously, that's a busy slide, and for a non-obstetrician, a lot of these treatment modalities or treatment options aren't particularly relevant. But the purpose of this slide is to highlight all the things that can be done by transferring a patient either from the birth suite or emergency department to the operating suite. So they're the main points I wanted to get across regarding PPH. I hope that was helpful. Any questions or comments, feel free to post below this video. And thanks very much for listening to Obcast.